Well, thank you so much, everyone, for joining us. We are very excited to have you here on behalf of the RDAR Center and our collaborators. I want to thank you for joining us. I want to thank Dr. Wang for joining us. Dr. Yan Wang is an assistant professor in the Department of Epidemiology at the University of Florida, and her research focuses on leveraging advanced technologies and methods to improve monitoring and intervention of substance use, especially alcohol. She has a current R21 funded project through NIAAA, and that aims to validate a newly developed wrist-worn alcohol biosensor, which I think is what you're going to talk about today during the talk, in both laboratory and field settings. And this is also going to examine whether the biosensor works equivalently for persons living with or without HIV. In addition to this work, she also serves as the Associate Director of the Southern HIV and Alcohol Research Consortium and is the clinical core lead of the Consortium for Medical Marijuana Clinical Outcomes Research, funded by the state of Florida. That's a mouthful. So thank you so much for your time. Dr. Wang does have to leave a little bit early today for another obligation at 4. So after her talk, we will take questions if you have any before we hopefully move on to our next presenter. So thank you so much. I'm gonna go off video so everyone can focus on you, and please put questions in the chat if you have anything that comes up during the presentation. And then at the end of this session, we'll be able to have you unmute or also ask the questions as the moderator. So thanks again.
Thank you, Devin, for the introduction. So hi, everyone. I'm Yan Wang from UF. Today, I'm going to talk a little bit about the new generation wrist biosensor for alcohol use. And I will talk about the validation study we conducted and also a little bit about the future directions. So I have no conflicts of interest. So as we all know, alcohol biosensors emerge as a new tool for objective and continuous measure for alcohol use in naturalistic environments because we are aware of the limitation of self-report. And transdermal alcohol biosensors are a subcategory of the alcohol biosensors that are more commonly used. It detects 1% of alcohol excreted through skin, and it produces the reading called transdermal alcohol concentration, which is associated with blood alcohol concentration, but is not directly translatable to the blood alcohol concentration. So one of the most commonly used and validated transdermal alcohol biosensor is the ScramCam anklet to the left in the picture, as you can see. But it has several limitations that kind of limited its application in research settings. For example, as you can see in the picture, it's quite bulky device, so it has low acceptability among participants, according to a few studies, including one of ours. It involves high cost. It usually involves $1,500 for the device itself, and also around $8 daily monitoring fee. And because it's mainly used in the law enforcement setting, it's also associated with stigma. And also the sampling frequency is relatively low, 30 minutes per sample. So there's a need for more user-friendly biosensor that can be used in research and participants' daily life. So Backtrack Scan emerged in 2016 when NIAAA had their first wearable alcohol biosensor challenge. So Backtrack Skin actually won the first prize of that challenge. As you can see here in the pictures, it looks like a fitness tracker. It samples fairly quickly compared to the ScramCam every 20 seconds instead of every 30 minutes. And then the battery life is 2 to 3 days. The device itself can hold some data, but not for more than 48 hours. It takes about 1 hour to fully charge the device. And one limitation of the device is that it's currently not waterproof. So when we look at the software, it needs to be used in pair with its app called Skin app. So it's free for downloading, and it used mainly for data transmission. It also have the real-time data display function, but as you can see here, the units are not meaningful units. They are more arbitrary units that are not directly translatable to blood alcohol concentration. And there is a data portal that researchers can use to download the data. It's a cloud-based storage. You can download CSV files with the tech readings. There's a timestamp for each reading. There are also several additional sensors, including motion sensor, temperature sensor, readings that you can download, and there will be a count name and also the device ID. So the study I'm conducting is called AWARE study, alcohol wearables and research using EMA. It's funded by NIAAA as an R21. So the goal of this R21 project is really to validate this new device in the lab and also in the field use. And of course, we want to use it for future larger studies or projects, such as the one I kind of planned here on the right. So the aims of the AWARE study really is to validate, to assess the validity and reliability of the skin sensor in lab sessions and also in 2-week field session. So we also want to explore weather factors such as biological sex and HIV status that might contribute to individual differences in the transdermal readings. So just a little bit about the protocol itself. So we plan to recruit participants with and without HIV, a total of 40, 20 in each group. And as you can see, we are almost there with the recruitment goal. And each participant is supposed to complete a fixed dose lab session, actually 2 of them to test the reliability. So for each of the lab session, they will follow the standard protocol to fasting, with a standard snack before administration to mimic more real life alcohol consumption. We decide to do 3 beers in a row. So for each beer, they have 30 minutes, but they are required to finish the beer in 15 minutes. So there is a 15-minute break in between the beers. We take their breath alcohol concentration at the end of every 30 minutes for the drinking period, and then every 15 minutes until the level reaches zero. And for the field validation, we ask people to wear the device in their daily life for 2 weeks. And we ask them to also complete ecological momentary assessment using their smartphone to answer questions related to their drinking. And also whenever they have a drinking episode, we ask them to self-initiate an additional survey. So we so far recruited 38 participants, 12 with HIV, 26 without HIV. A little bit more than half were male. The mean age is 32, and we have a relatively wide range of age, primarily white, 17% Black, some Asian, some multiracial. Their mean BMI was 26. And due to COVID, not everybody completed all the study procedures as we planned. So the data I reported here were from 40 lab sessions and 34 2-week EMA periods. So first, when we tried to validate the device, we compared the tech reading with the BRAC reading in the lab sessions. So for some reason, the some of the earlier one, the lab session 1 for 25 participants we ran, the association was fairly low, R.32, not significant. But for lab session 2, for 19 participants, the correlation between TAC and BRAG was 0.7, and that was highly significant. And when we look at the consistency or the reliability, we can see here the peak TAC for the participants in lab session 1 and lab session 2 were moderately correlated, are equal to 0.56, and that was significant. And next, we want to know the latency of the TAC reading. As some of you may know, the transdermal alcohol reading usually delays compared to the blood alcohol concentration, because your body needs to process the alcohol before your skin can actually excrete some of the alcohol and to be detected. So we want to know how long does it take for skin to detect drinking. We use the change point package in R to detect elevated reading from the baseline. So if you ever used a skin sensor, you know there is no absolute 0 as the baseline. So it's kind of readings around 0 fluctuates a little bit as a baseline. You can see here. So the change point package applies some algorithm to detect the significantly elevation from the baseline level. And we call the first change point as the detection time. So for example, when we see here, the 3 drinks were administered at the 3 different times. And if after first drink, if the change point occurs here, then we can see after about 10 minutes, the drinking was detected by the skin device. And in contrast, if after 2 drinks, the change point occurred, then the detection actually happened after 2 drinks, and that was almost 15 minutes after their first initiation of the drinking. So here's a summary of what we found. So the latency from their first drink to the detection was actually 38 minutes. So that means after their initiation of first beer, it takes skin sensor on average 38 minutes to detect the drinking. And then after, so when we talk about detection here, we are talking about detecting the whole drinking episode. So after 7 minutes of their second beer initiation, the detection, so the device already detected the drinking. And then after their third beer, the number become negative. That means the drinking was already detected before they started their third drink. And then we calculate the detection rate based on a similar concept. So if the change point occurred before the first beer ends, then we say it's successfully detected. So the detection rate here for after first beer is 18%. After second beer, 2/3 of the drinking were detected. And then after their third beer, 95% detection rate. When we look at the field validation, because there's no established software for data analysis, we actually use 2 independent coders to determine whether there was a drinking curve and also to identify the peak TAC of that particular drinking curve for each drinking episode. So if there is no obvious drinking curve, then the detection was not successful. So out of 161 self-reported drinking episodes in the EMA, 79% of them were actually detected by skin. So among those, the lower level drinks were less likely to be detected. So the detection rate was 62%. And for higher level 3 or more drinks, the detection rate was actually 91%. And when we look at the correlation between peak TAC detected by the skin and number of self-reported drinks, the correlation was moderate, 0.64, and it's actually statistically significant. And we also built a multi-level model to see whether biological sex or HIV status on top of EMA self-reported number of drinks predicted TAC value in the field. So it turned out only the self-reported drinks, number of drinks was the significant predictor. And of course, we have a relatively small sample, so that could be why we're not powered to detect any group differences. And then we also ask participants to rate the usability and acceptability of the skin sensor. As you can see here, the red box actually indicates items that are positive. And as you can see here, most of them are on the 3 or 4 points, meaning that participants agree with this. So the scale is from 1 strongly disagree to 5 strongly agree. And then for those negative items, participants mainly disagree with them. And also interestingly, participants reported that the skin sensor actually didn't influence their drinking and didn't make them drink less, which is not hard to understand because in my study, we mainly ask people to wear the device, not to change their behavior. So it's purely observational. It could change if we ask people to do some, for example, if we incentivize people for not drink, that might make a difference. We also collected qualitative feedbacks after the 2 week of field use, in addition to the skills I just presented. So we asked participants what they liked about skin, what they didn't like, and also if there are desirable features, what would they recommend. So participants reported they liked the lightweight and also the shape looks like a watch. They said they like the device being discreet, simple to use, never have to think about it, being comfortable, sleek, no low profile, convenient, and also like the fact that it is able to detect alcohol use. But they also didn't like the aspect, a lot of that is with the data uploading. Many participants experienced difficulty with the data uploading, and they didn't like that it's not waterproof. So they have to take it off when they're showering, or there might be some water exposure. And also currently there is no battery life on display on the app. So people want to know when the battery is dying so that they can charge it in time. And they also commented that the strap comes off easily. They want to know the blood alcohol concentration level in addition to the curve that's shown. And currently this is only compatible with iOS, not Android system. And they commented on the app, sometimes it's hard to sync. They had to sync constantly. And also the app would crash a lot. And in terms of what they wanted automatic data uploading. They wanted improved connection to the app. And also, as mentioned, they wanted the intoxication level, longer battery life, indicator for charging. They wanted to be waterproof, and improve the design to help prevent device sliding. So just a quick summary, the skin biosensor was able to detect drinking in both laboratory and field settings with some latency. So our study showed 38 minutes after drinking initiation, and some other studies we published before, and also some other researchers' study showed about the same range. They have, I think, around 25 minutes. So we are a little longer, but they usually have a single dose administration, which is different paradigm compared to what we have here. So the detection rate after 3 standard drinks was 95%. Which was pretty good. Detection rate in the field was 79%, but think about heavier drinking episodes, it was 91%. The validity was acceptable using BREC or self-reported number of drinks as the gold standard. Reliability was moderate in repeated measures within subject. And usability acceptability was high for field use with low influence on drinking behaviors. I know some researchers are concerned that when participants see their readings, they may modify their behaviors, but it looks like if you're not asking people to do that, the impact was minimal, at least in my study. So some future directions, obviously there's a need for more rigorous validation using larger and diverse samples. My study is only 40 people. We obviously want to know more about individual differences, as we know there is huge interpersonal differences in transdermal alcohol concentration. And there is also an urgent need for automated data processing and analyzing software. So also there is need for methods to estimate blood alcohol concentration from the transdermal alcohol concentration readings. There has been some work that's been done by Catherine Fairbairn and her lab. So if you're interested, you can look up her work in that. And then in the future, ideally, wearable devices should be integrated with other mHealth tools so that we can have a nice mHealth suite to either use it as a monitoring tool or as an intervention tool. So we do have 2 pending PO1s that both of them involve the use of the skin biosensor. And so in one of them, we're proposing to use machine learning to come up with algorithm to automatically detect drinking in the field, and then also use engagement software to promote self-management among youth with HIV. And the other one, we're using skin as a secondary validation tool for contingency management. So with that, I would like to acknowledge my collaborators, students and staff who helped with all this work, and also NIAAA program officers who have been very supportive of this line of work, and of course my funding from NIAAA. That's the end of my presentation. Thank you for listening.